Okay, Casey. Hi. The first one I'm going to do is the spinal. You're going to bring your patient into the room. You're going to get them into a cat-like posture. And first you're going to palpate, without being sterile, 2 Fier's line by finding the posterior superior iliac crest and tracing the midline. That should be the space between the L4, L5. And when you find that, you mark it with like a pen cap or something, just like a little target area. Then you open up your kit. You have monitors on the patient also. Then you open up your kit. You sterilely draw up your localizer needle that you're going to be using to make the wheel. And you also sterilely draw up your actual spinal needle with the local anesthetic you're going to use. So then you would put on your sterile gloves. And you're going to prep the patient. So you're going to prep midline and then go out, and then you throw it away. Midline and then go out in a circle and then throw it away. Midline and then go out in a circle and then throw it away. Then you would put a drape on the patient. This drape is kind of stuck together, so we won't use it. Then you have your localizer needle that you're going to create your wheel with. So you have this whole area is sterile here because there's a drape around it and you prepped all that. So you kind of like refined the spot you want to go. You make sure that that's the spot you want to go. And you have this filled with just lidocaine. And you go in and you kind of use this to mark your anatomy to make sure you're not hitting os. And also you make your wheel at first, which is just, you know, the subcutaneous little wheel there. And then you go in and you're giving lidocaine as you go in and as you're coming out, making sure you have a clear path right there. Okay, so then you would have given all that. Now you're done with that. Then the next thing you're going to use is your spinal needle that has the stylet in it. So you see that area where the little, maybe a little mark was made, and you get ready to go in. Go in midline, slowly, and as you go in, you're going through skin, then sub-Q fat, then you're going to the through the supraspinous ligament, then the interspinous ligament, which might feel firmer to you than the other ligaments. Then you'll be going through the ligamentum flavum, which might feel kind of gritty. Then you might feel a pop, but you're going to go beyond that. And you will feel another pop when you go beyond the arachnoid matter, because then you would be in the subarachnoid space, which is where you want to be for a spinal. And you're doing this very gently. And if the patient says, oh, that hurts down my right side or hurts down my left side, you redirect in the opposite direction. And then when you think you're in the spinal space, you pull your stylet out. And you will get CSF flow back. There it is. So you get like a little CSF flow. And when you're happy with that, so this stylet will go here. Then you also have your syringe that has, and you're not just like letting them drip, you know, the whole time. This is quicker. Then you have your syringe for your spinal that you're going to be doing. When you do this, you are going to aspirate, and you're hoping to see CSF, a swirl in there, and not blood, which would mean that you're in the intravascular space. And so you aspirate, positive CSF, no blood, and then you inject. And then when you have 1 cc left, you aspirate again and inject. And then you take this whole thing out all at once. And then you have the patient lie flat, and during this you're watching to make sure that you're not, you have the monitors on, so you are watching, you're hoping for a total spinal as a result. We'll go over what it would mean if you were in intravascular space when I do the epidural video. You would lie the patient flat, and then you start marking their dermatome levels as the spinal takes effect. A level of T4 would be the nipples and below. Okay.